In this video, we are going to discuss about ECG changes in potassium abnormalities like in the hypokalemia and hyperkalemia. Potassium is vital for regulating the normal electrical activity of the heart. Decreased extracellular potassium causes myocardial hyperexcitability with the potential to develop reentrant arrhythmias. Increased extracellular potassium reduces myocardial excitability with depression of both pacemaking and the conducting tissue. Normal serum potassium level is between the 3.5 to 5.5 millimole per liter. When the serum potassium level becomes less than 3.5, it is called the hypokalemia, and when it is more than 5.5 millimole per liter, it is called the hyperkalemia. Both the hypokalemia and the hyperkalemia can be divided into mild, moderate, and severe. The mild hypokalemia, when the potassium level is between the 3 to 3.5, moderate when it is between the 2.5 to 2.9, and when it is less than 2.5 millimole per liter, it is called the severe hypokalemia. And when the potassium level is between the 5.5 to 6.4, it is called the mild hyperkalemia. Between the 6.5 to 7.5, it is called the moderate hyperkalemia. And when the potassium level is more than 7.5 millimole per liter, it is called the severe hyperkalemia. ECG changes in hypokalemia. Hypokalemia is defined as serum potassium level less than 3.5 millimole per liter. ECG changes generally do not manifest until there is modest degree of the hypokalemia. That means when the potassium level is less than 2.9 millimole per liter, ECG changes noted. The earliest ECG manifestation of hypokalemia is decrease in the T wave amplitude. The ECG features of hypokalemia when the potassium level less than 2.7 millimole per liter are increased P wave amplitude, prolongation of the PR interval, widespread ST depression and T wave flattening or T wave inversion, prominent U waves. The U waves are best seen in the precordial leads V2 and V3. Apparent long QT interval due to fusion of the T with the U waves, or we can say long QU interval. With worsening hypokalemia, when the hypokalemia becomes severe, that is associated with frequent supraventricular and ventricular ectopics, supraventricular tachyarrhythmias like the atrial fibrillation, atrial flutter, atrial tachycardia, potential to develop life-threatening ventricular arrhythmias like the ventricular tachycardia, ventricular fibrillation, and torsades de pointes. Hypokalemia is often associated with the hypomagnesemia, which increases the risk of malignant ventricular arrhythmias. So it is better to check both the potassium and the magnesium level in any patient with arrhythmia. Replacement of the potassium to more than equals to 4 millimole per liter and magnesium to more than equals to 1 millimole per liter to stabilize the myocardium and protect against arrhythmias. So the ECG features of hypokalemia are, as we are seeing in the ECG tracing, increased P wave amplitude, prolongation of the PR interval, widespread ST depression, T wave flattening, prominent U wave, and apparently long QT interval. ECG changes in hyperkalemia. Hyperkalemia is defined as a serum potassium level of more than 5.5 millimole per liter. ECG changes generally do not manifest until there is modest degree of hyperkalemia, that is more than equals to 6 millimole per liter. The earliest manifestation of hyperkalemia is an increase in the T wave amplitude. Features of hyperkalemia: peaked T wave, P wave widening or flattening, PR prolongation, bradyarrhythmias, sinus bradycardia, high-grade AV block with slow junctional and ventricular escape rhythm, slow atrial fibrillation, conduction blocks like the bundled branch block, fascicular block, QRS widening with Vijay QRS morphology. With worsening hyperkalemia, when the potassium level is more than 9 millimole per liter, there is development of sine wave appearance, pre-terminal rhythm, ventricular fibrillation, pulseless electrical activity with Vijay wide complex rhythm, asystole. The patient with renal failure on hemodialysis or taking any combination of ACE inhibitors, potassium sparing diuretics, and potassium supplement If develop a new bradyarrhythmia or AV block, then always suspect hyperkalemia. Serum potassium level may not correlate closely with the ECG changes. Patient with relatively normal ECG can suffer sudden hyperkalemia cardiac arrest. In any patient who has suffered a bradycardia, pulseless electrical activity arrest, suspect and treat for hyperkalemia. Still, we can expect the following ECG changes according to the serum potassium level. When the serum potassium is more than 5.5 milliequivalent per liter, there is peaked T wave, tall, narrow and tent-shaped T wave. When the serum potassium is more than 6.5 milliequivalent per liter, there is P wave widening and flattening of the P wave noted. Also, there is lengthening of PR interval. As hyperkalemia becomes more severe, the atrial depolarization may be impaired, causing the P waves to flatten or disappear. High potassium level can delay the conduction of the electrical impulses through the AV node. This leads to longer PR interval on the ECG. When there is serum potassium more than 7 milliequivalent per liter, there is widening of the QRS complex. As hyperkalemia's impact on heart's electrical system, there is slow ventricular conduction that leads to broader QRS complex. Along with there is bradyarrhythmias as well as various types of conduction block. When the serum potassium level is about 9 milliequivalent per liter, there is development of the sine wave pattern which indicates imminent cardiac arrest. This is a warning sign. When the serum potassium level is more than 9 milliequivalent per liter, then the interval and the waves continue to prolong and ultimately leads to cardiac arrest. Just to recap, when the serum potassium level is more than 5.5 milliequivalent per liter, there is peaked T wave. When the serum potassium level is more than 6.5 milliequivalent per liter, there is widening or flattening of P waves along with PR interval prolongation. When the serum potassium more than 7 milliequivalent per liter, there is QRS prolongation. At the 8 to 9 milliequivalent per liter, there is sine wave pattern. At the level more than 9 milliequivalent per liter, there is cardiac arrest. If you like the video, please like, comment and subscribe.